I'm Dr. Shawn Tassone. Welcome to Confessions of a Male Gynecologist, a podcast dedicated to women's health and hormones, and pretty much everything else you were never listened to when you went to the doctor's office. I'm board certified in OBGYN and integrative medicine, and I have a PhD in mind-body medicine. I guess you could say I'm a little bit outside of the box. In this podcast, I'm going to get you the answers you probably asked 5 other doctors and were kind of blown off. I want you to know that I'm not only here to talk, I'm here to listen as well. And now, let's get to those confessions. Hey everybody, welcome back to another episode of Confessions of a Male Gynecologist. I'm your host, Dr. Shawn Tassone, and with me today, I have a doctor that I have been following for a while, and it's kind of interesting how things happen, but we are now both part of the medical advisory team for Modern Thyroid Clinic. So when McCall McPherson, who's been on the show a couple times, told me that Cassie Smith was joining, I was excited because, as you all are acutely aware, if you follow me, I like doctors that kind of push the envelope, but at the same time, use their MD to kind of parcel out the research, what's good, what's bad, and don't necessarily fall into that category of selling T-shirts and stuff like that. And Dr. Smith is one of those people. So first of all, thank you for coming on. What I'd like to know from you, because actually I don't know a lot about your background other than you're a board certified endocrinologist, but kind of, how we all get to where we are today, maybe based on personal journeys, stories, injuries, medical things. How did you get to modern endocrinology where you are? Because I will tell you, and I don't mean this disrespectfully, but if I had to pick a group of physicians that are jerks, it tends to be endocrinologists. And I don't know why, but maybe we can get into that. But you're not one of them. And they're rare finds. So how did you get to this place?
Well, thank you for having me, Dr. Shawn, and thank you for not thinking I'm a jerk.
No, of course.
I would agree that in general, endocrinologists can just be a different group of people. But my journey kind of started by way of a lot of people, like McCall's, I was just really sick whenever I was younger. And even though it kind of started when I was in medical school, I got Graves' disease. Thought I was dying in the ICU one day. Like I got super tachycardic. My heart was beating really fast. I was dizzy. And I thought, well, maybe I'm just really anxious. Turns out I had Graves' disease.
Wow.
And so I, was told, oh, you're going to take this medication and everything's going to be fine. Well, that methimazole medication made me feel really bad. And so everything wasn't fine. And so then the suggestion was, well, let's just give you this pill and irradiate your thyroid. And that just didn't sound like a good idea to me as a third-year medical student. I was like, I feel like your thyroid's a pretty important organ. Maybe we should try to figure out what's actually causing this. And that just really made a lot of people angry. Like a lot of doctors were like, why are you questioning this? There's nothing, wrong with you. There's no way that you're going to fix this. It's just part of you, and you need to take this medicine, or you need to take this pill that's going to kill your thyroid, or you need to have surgery. And I just didn't like any of those answers. My dad will tell you that even as a child, I like to ask why a lot, to the point where he probably hated me as a child, but I just always wanted to understand why. Mm-hmm. And so that's kind of where my journey started in medical school. And then eventually I went into remission, and then unfortunately I ended up with Hashimoto's. So while I was in residency, I had Hashimoto's, and then I got PCOS, and then I got insulin resistance, but everyone told me, well, there's no way that really anything's wrong with you because you're skinny. And it was just this nobody took me seriously, right? I couldn't find a cool gynecologist like you, but I was reading all the stuff and I'm like, no, I know I have PCOS because I meet the Rotterdam criteria. I know, I have this family history of diabetes. My fasting insulin's actually really high, even though I'm skinny. So it was just really annoying. Nobody listened to me or took me seriously, like all of your listeners, I'm assuming. And so even when I graduated medical school, I actually was an internal medicine doctor for a year. And I was still so annoyed that first of all, my patients weren't getting better. But then anytime I tried to get an answer as to why was my thyroid overworking and now it's underworking and what can I do to make it better other than just take all these medicines, no endocrinologist could tell me. I saw a bunch of them. And so I got really mad and I was like, I'm going to go back to fellowship and not be that like stupid endocrinologist that can't answer all those questions.
Yeah. Yeah.
So that's kind of how I got to where I am. And, just kind of learning by myself or on myself, with my patients and just kind of continuing to try to figure out what is the best way to deal with things like autoimmune diseases or just anything in general as a patient myself. So.
Yeah, so basically you kind of came up through that you had the injury, the wounded healer.
Mhm.
I had a friend who's an endocrinologist and he had childhood diabetes, and you grow up kind of wanting to understand the process. But I resonate with you saying why, because I was when I did medical school, the military paid for it. And so I had to do my payback. And the military is literally the worst place to ask why, because there is no answer. And it makes you extremely frustrated. And I think, not pushing, not asking why just doesn't, for any doctor, I think it just puts you into that box that, you just turn into this kind of automaton. And I see that a lot with thyroid because, I never used to treat thyroid as a younger doctor because I was always afraid of the thyroid. We're always taught that you just don't mess with the thyroid. It's so you don't want to cut off the brain, thyroid connection. And then I started finding all these women who would come in with like what I would call subclinically hypothyroid, where they don't meet lab criteria per se, but they have every single symptom in the book, from fatigue to hair thinning to weight gain and cold all the time. So do you think, currently the lab values to me are pretty wide ranging on thyroid? I would send somebody to an endocrinologist because their TSH was 5 or outside of the normal range, but then they would kick them back and say, "Oh, we don't worry about it until it's 10." And
Mhm.
it's like, do you think that in general, endocrinology is kind of, as gynecology, kind of behind the curve a little bit in treating like thyroid disorders? I mean, do they look at thyroid as kind of like, I don't know, and it's got to be really bad before they get involved?
I think that endocrinology is behind the times, like in everything, to be honest
Okay.
with you. Not only thyroid, but they don't treat hormones very well. And you just kind of get into this, you get indoctrinated into this like brainwash cult of like, well, the Endocrine Society guidelines say that you're technically not hypothyroid unless your TSH is 10. And so, okay. But the interesting thing is, Jeff Garber is the guy who wrote those guidelines. We haven't updated them since 2012,
Yeah.
which is pretty embarrassing.
Yeah.
He also has published papers since those guidelines were written saying that TSH is a great marker for thyroid function, except, and he lists like a million different reasons when it's not a good indicator. And it's like when you're inflamed, when you have insulin resistance, when you take metformin,
Life.
when you take opiate, when you take OCPs, when you take SSRIs. I'm like, so that's like 100 million people. Okay, so maybe we should update our guidelines, right? And so I just think endocrinology, like most traditional medicine doctors, like you said, it's very like robotic. When you're in school, it's like, if
Mhm.
this, then this, if this, then this. And it's very individualized and everyone's in their lane, right? Like you're taught, oh, this is the cardiologist issue. We're taught like, oh, this is the primary care doctor's issue. Oh, no, this is like a person that you look at the
Right.
whole person to try to figure out how to fix the person, right? Like I tell people all the time, like if your car was rattling and it was like broken and you took it to a mechanic, if you took your car to a mechanic and handed them the keys and they turned it on and it rattled and then they got out and just kind of looked at it and handed you the keys back, you would be like, what the heck? Well, that's what we do as doctors. Like, no, you have to open the hood, you have to look at what's going on and like put it back together, right? But for some reason, we don't do that in traditional medicine. And I mean, I don't really think that any group does a great job of what they're really supposed to
Yeah.
do from a functional perspective, right? But we're not taught that. So in school, to be honest with you, I went to a pretty good fellowship. We learn about hormones very minutely, which hormones are a huge part of your, estrogen, testosterone, progesterone, women and men. we were taught that, oh, yes, your thyroid, you put them in this box and then move them along. And they really focus on diabetes, unfortunately or fortunately, in fellowship because so many people have diabetes.
Yeah, and that's kind of what I learned over time was that I would refer to endocrine if I had a new onset diabetic, or now I'll refer if it's a new onset hyperthyroid patient, just so I don't
Mhm.
miss something. But let's talk about the labs. We talked about TSH. And I think what's interesting is people don't understand that TSH isn't really a thyroid hormone. It's a brain hormone that basically just
Mhm.
tells your brain, does that, or tells your thyroid what to do. Does TSH vary like throughout the day or throughout the menstrual cycle? Is there, when should women worry when their TSH is a certain number? What is it that you usually look for?
Yeah, so I think that's a good question, but I think you can't really know what's going on unless you also look at free T3 and free T4. So TSH is a very general hormone. Like you said, it's a pituitary hormone, it's not an actual thyroid hormone. Our pituitary makes TSH
Mhm.
to then stimulate our thyroid to make T4 and T3, which are active thyroid hormones. But the thing with the TSH is, again, there are so many things that can change it. If you're chronically stressed, if you're fasting, if you take statin or oral contraception or metformin, or are you inflamed, do you have gut issues as you age? And so there's just so many things that make your TSH fluctuate throughout the day that, like, I'll get it, I guess, for like a pulse check, but I mean, I look at it and, like, what you really need to know is what is your free T3 and your free T4. In addition to that, though, the number one thing that is so important that nobody cares about is, like, how does your patient feel, right?
Right.
Because we have millions of people whose labs and how they feel are totally different. And so obviously there's a disconnect there. And I think it's because your blood work is never going to show how much hormone is in an actual cell. Unfortunately, we can't test that currently, right? And
Right.
we all know that hormones have to go into cells in order to work. Any hormone, testosterone, estrogen, thyroid hormone, if the doors to your cell are locked because you're inflamed, because you have insulin resistance, because whatever, it doesn't even matter how much hormone is in your blood if it can't get into the cell. So, this is why there are millions of people who have true hypothyroid symptoms. They probably are hypothyroid and their blood work may look normal. And it's because we just don't have a way to validate yet that those hormones aren't actually in the tissue. So, I tell people, if you truly, I mean, you are an N of one and you know yourself. So if you have true symptoms of hypothyroidism, or something's not right, you're tired, you're cold, your hair's falling out, whatever, then you need to be concerned and you need to find a provider that's concerned too and is trying to help you figure out how do we make this better, right?
Yeah, and the other thing I think that this falls under is when most people come to me, or even when they go to endocrinologists that I have seen, again, not throwing shade, just what I've seen,
Yeah.
they get the TSH and a free T4. And they don't ever order the free T3, or they'll just put people on Synthroid or levothyroxine. I find and this is a grand generalization, but I find that most endocrinologists don't want to prescribe liothyronine. They usually fall. Is there a reason behind that? Like, is there a teaching that goes on in the fellowship that most people will convert into T3, or why is that? Because I really don't see that very often. Like, I hardly ever see anyone on liothyronine.
So honestly, in fellowship, nobody ever even talked to me about T3 ever, not
Wow.
once,
Wow.
period. So I think the teaching is you go off the TSH and you adjust the TSH and then you tell them that they're fine. Now, the caveat to that too is, like, most fellowships, think about it, right? Most teaching facilities, I mean, you're like seeing a bunch of people all day long. It's like you're not asking people how do they feel. And remember when you're a fellow or a resident, it's like, go and see the patient in the hospital. Are they good enough to discharge them? It's not like, how are you feeling? No, it's just like, if they're ready, kick them out the door. I think that's how it is in all training programs, right? And so nobody ever even talked to me about T3 and fellowship ever, like not once, wasn't brought up. And so they don't teach you that. So then I do think people are scared because there is this misconception of like, oh, T3 can cause you to have arrhythmias and strokes and whatever the crazy thing is that people say, which none of that is true. None of that has been validated. You can have an increased risk of osteoporosis if you have true Graves' disease, where your
Right.
body is actually making too much thyroid hormone, but never if you give someone too much thyroid hormone,
Well, that's the
unless you're
theory,
just
but if the TSH is suppressed, you could get
right.
osteoporosis, but you're saying it's because you're hyperthyroid, not because we're giving you T3.
Unless you're just doing it so like irresponsibly. I mean, if you're giving someone 50 mics of Cytomel 3 times a day or something crazy like that, then we need to talk. But in general, no, that's
Right.
not going to happen 99.999% of the time. And I've seen, tons of people who have T3 levels maybe that are even a little high, 4, 5, 6,
Right.
because we're trying to get that hormone into their cell. They have zero symptoms of hyperthyroidism. They're treated like that for years. It doesn't affect their bones. And that's never been shown unless you have true autonomous, meaning your body is making incredible amounts of T3 for a long period of time, which is probably not going to happen either because as a former Graves patient, I'm going to tell you, when you're setting down and your heart rate's 130 and you're dizzy, you're not going to live like that for 3 years. Like
Right.
it's not fun.
Well, before we leave thyroid, I've got two questions. One is on T2 because there is
Mhm.
a influencer out there that sells a T2 supplement and blah blah blah. Is T2 relevant to the discussion?
Yeah, I mean, I don't think that we have enough information to say that it is. I mean, could you hypothetically? I think a lot of people like their claim to fame with T2 is like, oh, well, when you put somebody on desiccated thyroid medication, they feel better. And that's because it has T1 and T2. I think it's probably because desiccated thyroid medication has a lot of T3, and that's what we
Right.
actually need,
Right.
right? Does
Right.
it also have a little bit of T1 and T2? Sure. But like, am I going to go out of my way to prescribe someone T1 and T2? Never.
Right. Okay. And the last thing, I have been stubborn on this issue. I've gone round and round with McCall on it. I've lost followers over it, but I want you to tell me flat out, is reverse T3 worth testing?
I think it is.
Okay. No,
I
and
think
I
it
don't,
is.
why is that?
Well, just because it gives you a gauge of how well your body is, like what is it doing? How is it converting T4 to T3? So if you have free T4, obviously we want it to make free T3, right? If your free T4 is all being shunted to reverse T3, then what that tells me is that we've got an internal problem. Like you're inflamed, something's going on. So we know that we're not getting as much free T3. And so I like to know because if it's really high, I'm like, okay, there are things going on, whether it be gut issues, whether it be high insulin, whether it be cortisol, so that we know, hey, how do we start ratcheting that back down and moving that back to the free T3 level? Now, is it going to change like how much T3 I'm giving them directly? I mean, if their T3 level is good, no. I mean, it's not like I'm going to give them more T3 if their T3 level is good, but it's going to tell me about them as a whole. Like, hey, we got to figure out how to re-shunt this. And that means their deiodinase 3 is really high and their, 1 and 2, their deiodinases are out of balance. So that tells me something's going on in their gut, most likely. So that's why I like to know.
So if you have someone with a high reverse T3, you will kind of work on the gut and inflammation.
Most of the time the gut, I'll make sure that I know what their insulin is and their cortisol. If their insulin's really high, I start working on that. If their cortisol is really high, we start talking about, the gut brain connection. I saw a lady today, like super stressed lady, very sweet, eats amazing, but like she has an astronomical amount of stress. And she's like, I mean, other than tired, I'm fine. And I've been trying to get her thyroid fixed forever, and her thyroid looks really good. And I think the problem is, well, her reverse T3 has been high forever. And although her T3 is okay, it can't get into her cell because her cortisol is 22. She's got some gut issues. And so like, I think it's just another piece of the puzzle to show her, like today I showed her your reverse T3 is 39. So
Mhm.
we've got to figure out
Okay.
something with your
Yeah.
stress.
Okay. Well,
So
I'm going to start adding it to my panel then because you now have convinced
sorry.
me. But I won't throw in. McCall's going to get mad because I didn't do it when she told me to, but I'll do it when you tell me to. Um, so you kind of mentioned cortisol, and I'll tell you what. Right now, and you're on internet all the time as well.
Mhm.
That's the big thing on Instagram right now. All these coaches and blah, blah, blah
Mhm.
have their cortisol cocktails. I must
Mhm.
get asked this probably 5, 6 times a day. I mean, obviously, we look at cortisol as you got on one end, you got Cushing's, on the other end, you got Addison's when there's none. But then you have this great zone in between that's just this chasm. First of all, what's your favorite way of testing cortisol?
So initial baseline testing, I like to check a blood level at 8 a.m. just to get again, like environmental, like, are we good? Are we, now if I check a morning cortisol and it looks good, it's like 12, but somebody tells me, I lay down at night, my heart's beating, I can't go to sleep, I wake up in the middle of the night, my heart's beating, like I think there's issues with their cortisol, then I'm going to do some salivary testing. But just to get like an overall baseline picture or some urinary testing. I just do a blood test to start because salivary and urinary are more difficult to do and they're
Mhm.
expensive.
Right.
So I'm not saying that you don't need it, but I think for a general baseline, you can get an idea of doing a morning 8 a.m. by the latest 9 a.m. serum cortisol level, assuming that patient hasn't had any steroid in the last month.
Okay. And then if you have somebody that say has a panel, they do the 4-point test, saliva, urine,
Mhm.
and it looks like throughout most of the day they're elevated. Obviously, that can interfere with thyroid, and like as you said. But what would you do for that person to try and get their cortisol under control?
That's a good question. So then you start to look at, you know, what is their insulin high as well? So I look at that, right? Because cortisol and insulin go together. What is their progesterone doing, right? So unfortunately, a lot of women my age, late 30s, early 40s, this is when we start to lose our progesterone. Interestingly, when we lose our progesterone and cortisol are teeter totters. So
Okay.
if you lose your progesterone really quickly, it can spike your cortisol because it stresses your body out because progesterone is our happy hormone. So then I start thinking about, okay, well, what is their progesterone status? We talk about sleep, we talk about, just anxiety, stress, things like that, and their gut. And again, I mean, if their thyroid's off, this is why I like the big picture, right? If you've got a bunch of symptoms pointing towards there's a lot going on and it could be their gut, then a lot of times it comes back to the gut. But those are kind of some of the things we talk about. Are you sleeping or are you waking up in the middle of the night? What is your stress load like? A lot of times, honestly, I have also, if you're listening to this and you're in your late 30s, early 40s, and you're still on birth control can wreak havoc on your cortisol. I mean, it really can. And so OCPs, like I would say, if I have a lady who's on an OCP and she has high cortisol, 95% of the time, if I can get her to stop her birth control, her cortisol drops instantly. So
Wow.
looking at things like that. Yeah. And I've done tests to prove it. You can do what's called a DEX suppression test. So I'll leave somebody on their OCP and I'll DEX suppress them and I can show their cortisol will come down, meaning that it's not something internally that's causing their cortisol
Right.
to be high. So I know it's not hurting them. And then if I can ever, and then like, I'll be like, okay, just humor me and get off your birth control for 1 month and let's check it. And every time they'll get off their birth control and it will go 27, 28, 29 into the teens, like every single time. So birth control, and if you think about it, it makes sense, right? Because birth control is going to make our body not make progesterone and estrogen because we're tricking ourselves by giving ourselves small amounts
Sure.
of hormones, right?
Yeah.
So if your body's not making progesterone, even though you have a synthetic one, your body doesn't recognize that as the same. And so it drives your cortisol up.
So, what are the long-term effects, short of Cushing's disease, of a high cortisol?
Oh my gosh, it's so many, Dr. Shawn. So like again, it stresses your body out, right? So when your cortisol is high, a lot of times it's going to make your insulin high. So I think this is why a lot of the United States has insulin resistance, type 2 diabetes, and obesity. So when your cortisol stays high for a really long time, you're going to gain weight around your midsection. You're going to increase your visceral fat. These are the worst things this is the worst way to gain weight. It's going to ruin your gut. So high cortisol causes leaky gut, causes you to have increased risk of SIBO, small intestinal bacterial overgrowth, and H. pylori. It long term, if it's really high, can affect your bones, right? Because again, it's going to suppress progesterone. And then as your cortisol goes up, your insulin's going to go up. And when your insulin's high, it's going to suppress your body's ability to make estrogen. It's going to affect your sleep. It's going to affect your body's ability to make growth hormone, which helps you sleep, and also thyroid hormone. So just so many things.
Yeah. And then on the flip side, So if somebody's like, how does somebody get to a state? Because I've seen women that have done like a Dutch and their cortisol is literally like riding the bottom of normal.
Mhm.
How do you, is that kind of like just burnout? Like
Mhm.
you've been high for so long that your body's now just kind of crashing. Is that what causes a low cortisol like that?
I think so, honestly. I think it can be a lot of things that it can be autoimmune issues. So sometimes when
Okay.
you're developing Hashis or certain autoimmune conditions, we do know that autoimmune disease attacks your adrenal gland too. There's an antibody you can check for that.
Oh,
So I do think it's yes that we've just asked our adrenal gland to make, and it's like I'm tired, and so it
right.
just kind of stops, right? So it can be that. COVID when we had, when COVID was a thing, I guess if we can say that,
Mhm.
viruses can do it too. So COVID caused a lot of weird things with cortisol. I diagnosed so many people with adrenal insufficiency after COVID, and then eventually their adrenal gland would come back, which is very
Yeah.
interesting. A lot of things, but I do think that autoimmune conditions and just being stressed and inflamed, obviously, right? It puts more strain on your adrenal gland because when you're sick, your adrenals have to make more cortisol so that your body can try to get well.
What's your thought then on the other hormone, the big hormone from the adrenals, the DHEA? I have a lot of women that will self-treat. Unfortunately, it's like weird. DHEA is that you can buy it at the health food store, even though it's a hormone.
Mhm.
Do you find that DHEA corresponds to cortisol, or is it just kind of like, I mean, it's a high stress. I see it all the time where women are
Yeah.
mildly elevated and, it's just stress. But do you find that over time, DHEA being high can wreak havoc as well? Or is that just a marker for prolonged stress?
It can cause issues if your DHEA is high. Everyone's a little different depending on how they metabolize and different pathways. But some people have really like they'll end up with skin issues, hair issues from DHEA being really high, right? Like oily skin, depending on how the pathways, how
Right.
you metabolize your DHEA. And I do think it's kind of strange that you can just buy DHEA
Yeah.
over the counter when it's a pretty significant hormone. I check it sometimes. I will replace it in people at times too, but I don't think it's as important as some people make it out to be, at least not in women, because if you're replacing their testosterone correctly or their progesterone, estrogen, then a lot of times once you do that, your adrenal gland kind of calms itself down too, right? Your cortisol isn't as high, and then everything can flow through your adrenal gland like it's supposed to, and you'll make your own DHEA.
So, I get a lot of patients that will come in that are using the hormone called pregnenolone.
Hmm.
Um, I'm not a huge fan of treating pregnenolone just because you don't know where it's going to go.
Right.
Do you test for pregnenolone? Do you use pregnenolone in your practice?
I don't test for pregnenolone. I agree with you. Pregnenolone can go to cortisol, it can go to progesterone. Like there's a lot of things that can happen with that. So what you don't want is somebody who's got a really high cortisol and no progesterone taking pregnenolone and putting gasoline on the cortisol
Yeah.
fire and not helping the progesterone, right? So I don't test for it. I don't use a lot of it either. There is this camp of people who there's a thought process that it actually will help produce more melatonin and help with sleep. And some people swear by that. So if patients say, hey, I take pregnenolone and it helps me sleep, great. I'm not going to fight with you about it. Usually
Right.
it's pretty minimal numbers, but I don't necessarily test it and I don't use a ton of it.
Okay. So, when you get a female patient that comes in, we talked about hormones that I think are usually thought of as endocrine doctors, thyroid and cortisol, diabetes. Um, Talking about the diabetes part and uh, GLP-1s that have been out, they've been out for probably what, 20 years or so, maybe a little over.
1995 is when Vieta
Yeah.
came out.
So
A
30
long
years.
time. Yeah.
And it's like all of a sudden, they caught on. But I'm like, I honestly feel like GLP-1s are gonna transform obesity. And I mean, 5 to 10 years, once these are widely available for cheap, I think obesity will be gone. But I have a lot of patients that will ask, can what is the research? What does the research look like on long-term use of GLP-1s. And we've had diabetics on them for about 30 years now, probably on
Mhm.
fairly high doses. But what is your take on long-term use of GLP-1s?
Yeah, so that's exactly what I tell patients. So we've had Byetta since the 90s. It was a GLP-1 that came out for actually type 1 diabetics that they had to self-inject 4 times a day because it was such a
Oh,
short-acting GLP-1. And then we got the daily ones. We got Victoza, and then came semaglutide, and then they've just been ratcheting up since then. But all of the data that we have on long-term use with diabetics in very high doses, it's not alarming or concerning to me, like zero of it. We have, I guess, not large cohorts of data, I would say, on people who don't have diabetes. Although I will say, myself and some other practitioners that I know that practice functional medicine, if you put all of our patients together, you're looking at tens of thousands of patients who have done very low doses of GLP-1s for 3 to 5 years. I mean, I don't have patients that have significant issues. We just don't, if you know what you're doing, right? If you're dosing them correctly, because this is a hormone that your body naturally has. Like, I have it, you have it, we're born with it. Like, it is a hormone that we have. We lose it over time. And I don't think that you should recklessly give massive amounts of it, but I agree with you that it will change the trajectory of obesity in this country if it is given to people um, with education, right? So it's also not a just superpower miracle drug. So
right,
some people take this drug and think, okay, I can take this and still go through Starbucks and eat Krispy Kreme and Taco Bell and I'm going to lose weight. And that's not how the drug works.
right.
But I mean, there's no data. And I actually did research on GLP-1s in fellowship. So I actually helped do the research on for Novo Nordisk on semaglutide. So I helped publish papers with that. I did PIs for that. I saw patients on it. I mean, there's nothing that I've ever seen that has concerned me yet.
So what's interesting too is you see the evolution of these drugs. So semaglutide is a GLP-1. Then you had tirzepatide, which is a
Mhm.
GLP and GIP, and now they're talking about retatrutide, which I
Yep.
think hits 4 receptors or 4 things. Do
Three.
you, 3? Okay, so
Yeah.
but it's not out yet, right? It's still in trials, retatrutide.
Technically, retatrutide is still in trials. That is correct. Lilly is doing those trials. There is retatrutide compounded that people have used for over a year.
Okay,
And then there is also talk that there are other drugs in the pipeline with things like Lilly and Novo, which are even working on 4 and 5 and 6 receptors, which is insane.
right.
But yeah, so retatrutide has been available in clinical trials for over a year. And then, like I said, in the compounded world, probably for a year and a half. But it's just like it's because they know they work. They just keep kind of,
Yeah.
doing more and more research. And it's really fascinating too. And what I hope they start to look at as well is look at the gut microbiome with this
Mhm.
GLP-1s. Because what I will tell you is the people who are successful with GLP-1s, at least what I've seen in my practice, are also the people who have an emphasis or at least a focus on their gut. So a lot of people are insulin and leptin resistant because they have so many gut issues, right? They have leaky gut, they have, SIBO, H. pylori, things like that. It's really hard for those people to lose weight because when your gut is constantly spewing bad things out of it, it raises your cortisol, right? Constantly, because your gut's like, what is all this? What is going on? And then
Right.
that raises your insulin. And so it's almost like you're taking a drug that's counteracting what your body is doing. And so then those are the people who end up on really, really high doses and sometimes get bad side effects. And then unfortunately don't get the benefit of the drug because we missed the boat with like, hey, let's fix our gut while we add a GLP-1. So that's what we do at our practice is like, if you want to lose weight, we look at your gut, we look at your hormones, and we use very low doses of GLP-1s and we have astronomical weight losses. Like it's crazy because you're addressing their gut. And so there are certain receptors in your gut that these drugs like retatrutide and things can focus on. And I'm hopeful, I've been saying this for a couple of years. I actually wrote a letter to Eli Lilly. Like I'm hoping that you're looking at some of these pathways in people's guts, because if you can do that with the GLP-1, game over. Like y'all better buy some Lilly stock. Like, you know
When
what I
I probably could afford 1 share even
mean?
now.
Yeah, I know.
So when you talk about gut, you have said this multiple times. When you have a patient like you just talked about that is on a GLP-1, what's your test of choice? Like, what do you do to test the gut microbiome?
Yeah. And so there's a lot of back and forth about this too. And I actually did a reel on this and I haven't posted it because it's pretty dicey and I might really make some people mad. But there are all these people out there that say like, oh, do this test. You have to do this test. You need a DNA PCR test.
Okay.
And so what that looks like, and none of them are perfect, to be honest with you, like they aren't. But I know a lot of people prefer doctors' data and the GI map. The GI map is a PCR test. Some people say it's not. It is. I mean, 100% it's a PCR test. So
Okay.
is doctor's data. I personally use GI maps because I feel like the doctor's data, it gives you so much information that it is overwhelming to people and they just like stop and they don't
Mhm.
do anything. I
Okay.
think you can get a lot of information from a GI map that is very beneficial. And so that's what we use because I feel like I can sit down with the patient and go over 5 pages of information and it gives me everything about their good bacteria, bad bacteria, how they're digesting food, immune system, do they have leaky gut, do they have food allergies, are they allergic to gluten, like do they have parasites, worms, all of it's there. But you can go over that with a patient in 30 or 45 minutes and they get the gist of it and they understand and you can take actionable steps and you can help 95 to 97% of people. So I use GI map because I think in a grand scheme of things, it's the best test to move the needle. Then sometimes do you have to go back and do something more specific? Like if somebody has a parasite, there's specific parasite tests, stuff like that. But I like the GI map.
Okay, you brought up parasites, so now I got to talk about them. What anecdotally, what percentage do you think of people that you run a GI map on have actual parasites?
This is a great question. So in a GI map
I
or
only
a
asked
doctor,
because you can get a parasite cleanse pretty much on
right,
any Instagram page nowadays, so
right,
that's why I asked.
right. So in a GI map or in like a doctor's data test, 5%. Like it's not a lot,
Yeah,
maybe 10.
like that's
There
what I
is
was
a
thinking.
lot of jabber about parasites need a lot more sensitivity than those tests offer, which may be
Okay,
true. So interestingly, I just had a conversation on Tuesday. I'm going to be a part of a study with a company who has a very, very sensitive parasite test.
okay,
And they want to look at people who have no parasites on a GI map and see how
okay,
many they can find. And especially in people who, like, if you've had a GI map and you've done the protocol and then you're still having symptoms, but your GI map looks better, we're thinking like a lot of these people to get blamed that have SIBO, but the SIBO never gets better. There's some good thought and some good work by people out there that maybe they do have parasites and we just haven't picked them up. So on a GI map, I would say 5 to 10%. And if you would have asked me this question 2 weeks ago, I would have said 5 to 10%. But I saw some pretty compelling research recently that says maybe we have more than that and we just don't know. But do I think everyone should buy those parasite cleanses that you're talking about on Instagram and Facebook? No, I don't.
yeah.
Like, I think that's crazy.
Well, when you say parasites, like what are the parasites you see? Like what are the more common things you're seeing?
Usually they're amoebas, like Giardia is a pretty common one, right? It depends on how much you've traveled,
Yeah.
Indolax, like, but those are the most common ones. Now there's thought that maybe a lot more people have Giardia than actually it shows. And it's not like, not a ton of worms, anything like that. I
Right.
would say Giardia is the most common one though.
So you could have Giardia and not do these people have like diarrhea or do they just have stomach pain? Or, I mean, so you could have like an asymptomatic kind of Giardia you see.
100%. You
And
can.
does the GI map give you like concentrations of things? Like it tells you how many or a load?
It does. It gives you a load. I would say most people have bloating or pain or gas. A lot of people will have diarrhea. Almost sometimes it's like maybe they had diarrhea and it's like worn itself out. A lot of parasites, the other thought is like a lot of the parasites that you get, if they're in small enough amounts, if you're assuming you have a working immune system, your immune system's going to fight
Right.
it for you, right? But not everyone. So some people have no symptoms. Some people have terrible like pain, bloating, and then you have some with diarrhea. But I do think that these random things that you buy on Instagram, like you said, some of them can be dangerous. So like
Yeah.
I'm not in the camp of like, and also let's talk about these medical spas you can go to and get these water enemas and charcoal enemas and all this crazy stuff that a random nurse is putting up your butt. Like,
Yeah.
I don't think that that is safe either. Just going out there on a limb to say that. So.
I was looking at a post yesterday of this guy. He's like a fitness guy, and he was making fun of. He just flashed up all these pictures of people doing coffee enemas, like
Yeah.
on their balconies, and like the coffee bags hanging from the thing, and she's got her legs up in the air, and he's like, what happens to the person on the level below you if stuff? I mean, it's like if you're gonna do it in the tub. I'm not sure why you're out on your balcony, but yeah,
Yeah.
people are just, and I think part of the problem is, I'm in a lot of these doctor groups on like Facebook and stuff, and the doctors are always complaining, like they're all going to these alternative practitioners and these health coaches, and they're doing all these tests, and it's like, dumbass, it's because you're not doing anything.
Mhm.
You're kind of telling them they're fine, and they're not fine. So they want to find answers, and unfortunately, there's a lot of schleppy people out there, but and the thing about me that talking to folks like you, this makes me want to kind of do this kind of stuff because I kind of view you as one of the normies, which
Mhm.
might be good or bad, but you're making this work, and you know that, yeah, some of it, like you said, 5 to 10%, 90% of people are fine, which is kind of what I
Mhm.
would have thought. Like my fiance is from Mexico. She eats there all the time. She
Ugh.
constantly has gut issues. So it's like she probably needs a test.
Mhm. She
It's
needs
like
the
I've
GI
been,
map.
constantly,
Mhm.
it's either constipation or diarrhea or stomach pain or whatever. And it's like, this makes me want to have her do a GI map, because it's like, there's got to be something there, because she eats street food. You'll go there and they just think they get used to it. But it's like, then you live in the States for 10 or 15 years, then you go back and you're not used to it.
Mhm.
And you have all these things. So it's really fascinating to me.
Someone that eats in Mexico definitely needs a GI map. There's all sorts of stuff she could have. But to your point, yes, I think, I'm actually working on a provider training course for
Mhm.
gut health because I do think that, like, yes, there needs to be more providers that understand this. There's not really a good
Yeah.
one. I would love to put like a group together of doctors where we could all chat. I have a
Sign me up.
Facebook group that all my patients that do gut health, we put them in a group, and
Oh,
it's like it's been going on for years, and so it's really cool, they stay in there. So my new patients that are coming in that are experiencing things will go in there and chat, and then the ones that
yeah.
have already done it are like, no, it's this. And it's a really cool community too, because like once you fix your gut, it's just crazy how different it is. But to your point, it's like there was no textbook to go to for me to figure this out. Basically what happened was, once I got on my thyroid a little bit better and I was feeling great in 2022, all of a sudden I felt like I got hit by a truck. I was having some hormone issues. And then I literally couldn't get my thyroid back to where it was. And I was like, what the heck? And so I like struggled as an endocrinologist. And then I was reading all the information, like my antibodies went up really high again. I was reading all this information about high TPO and what it does to your gut. So I was like, screw it, I'm going to look at my gut. And I was mortified when I looked at my gut. I was like, this can't be right. I did another test. I was like, this
Yeah.
cannot be my gut. And then I was like, crap, now I don't know what to do with this. So I have to find someone to tell me what to do with this. Right. And so I went to a provider, they were explaining things, and I started learning about my own gut. And then I was like, there's no way I'm going to do this for 3 months, this gut study, right? Like,
Yeah.
this is
Yeah.
insane. And so my husband's like, just do it. Like, you're a mess. So within like 20 days, I was like,
Word the husband should never say.
well, he didn't say it like that, but he was like, please do it,
You're a mess, and he was never seen again. Okay.
No, he didn't say that. But so after like 3 to 4 weeks, I was like, I feel better. And by the time I finished it, I was like, this is crazy. And then I'm a huge numbers person. And so just by fixing my gut, my TPO antibody went from like 480 to 42 in
Yeah.
3 months. And I was like, and I felt so good. And then I rolled along in life until earlier this year, feeling great. And then I was like, I don't feel well again. Redid my levels. My antibodies were high again. My thyroid was being stupid. I had been super stressed. I did a gut study. I knew exactly what it was going to show. It did. So I got to do it all over again earlier this year. But it's like within 3 months, within 3 weeks, I was like, okay, yeah. I mean, your gut is so interconnected to your thyroid. It's crazy. And so a lot of people say it's voodoo. A lot of people say whatever. But, I tell people all the time, like, I have a clinic full of hundreds of people on a gut protocol all the time. So if it was so crazy, I mean, and my number one referral source for my gut studies is my current patients.
And do
100%.
you
Like,
see, we went to Oaxaca a few years ago and naturally got the diarrhea thing. And it wasn't going away. Like, I think I was like 3 weeks. Everything I'd eat just come right back out. So I did a real quick test here at the office and I had Shigella, which is not fun. I will tell you that. But it's like, I waited for like 3 weeks and I knew something was wrong. But some people live like that for years and
yeah.
months. And
I have a patient who lived like that for 10 years.
yeah, and that's too ridiculous to me. And I do feel inadequate when it comes to gut. And I'd be, sign me up for your program for sure, because I feel like, my next iteration of patient care is going to be to do a more inclusive membership thing where I can spend, because right now I got like or 30 minutes and I want to spend an hour and a half with people, but
Mhm.
you've got to have more information and then you need time to talk about it, like you just said. Do you find that just fixing the gut can help people lose weight?
100%. And I have a bunch of people that'll tell you that too. Like, I mean, I saw once they go through our gut health program and they're in their maintenance phase and they're good. I even have a lot of people who get off their GLP-1s and they still lose weight. I saw 3 people today who haven't been on a GLP-1 in 3 months who went through our gut health program. All 3 of them lost an additional 6 to 10 pounds in the last 3 months doing nothing different. Because if you think about it, once you fix your gut, right? So we have certain gut bacteria that are really important. One of them is Akkermansia. I know that's like a buzzword, but it
Yeah.
really is. And lactobacillus and bifidobacteria. Those 3 bacteria will literally take the food that you eat and completely change how your body extracts nutrients from it and what your body does with it. So if you're deficient in all 3 of those, which my people who come to me and they can't lose weight at all and they've been on GLP-1s and they're not losing weight, every single time when you look at their gut, they have no lactobacillus, no bifidobacteria, and no Akkermansia. And I tell them, it doesn't matter if you take 15 milligrams of Monjaro, you're not going to lose weight until we fix this. As soon as you fix those certain bacteria, those are the bacteria that make short chain fatty acids. And those are the bacteria that help us naturally use GLP-1 and lower insulin levels. They're full, they feel better, they sleep better, their thyroid works better. So 100%, I have people who fix their gut completely better. The lady I told you about that lived for 10 years with bad symptoms, this is partially my fault. So she's been my patient since I got out of fellowship in 2017, had diabetes. I've taken care of her forever. She always told me like, I have diarrhea, it's bloody. And I was like, it's probably your metformin. But and so finally in like 2023, I was like, let's just do a gut study. Like I talked her into it, right? We did a gut study. Her gut was terrible. We worked on her gut. We got her thyroid. We got her hormones right. Literally since 2023, I'm not exaggerating. I saw her 2 weeks ago. She's lost 94 pounds. She's off all of her diabetes medications, every single one of them, not on any of them. And she told me, I went on vacation with my husband and my kids last month for the first time in 10 years. And I didn't have to worry about where the bathroom was because I was always running to the bathroom to have to like poop. And I actually enjoyed my vacation for the first time in 10 years. And all we did was fix her gut. It's the craziest thing. And so she has sent me like 20 people. I see our whole family. But, it's really cool because she just had a terrible, and people with diabetes and people with insulin issues, their guts are awful because when your insulin's high, yeast grows. And a lot of these people have yeast in their gut and that makes their cravings worse. And then it makes their insulin worse. And then it makes their weight worse. And then it makes their thyroid worse. And it's crazy,
I'm gonna have my fiance come to you because we can't go to Ross or Hobby Lobby without going to the bathroom. So, and she doesn't listen to my podcast, so I can talk about her. But yeah, it's just and you don't think about it, but here's an off the wall question: have you ever seen something that you might think is unconnected, like hypertension?
Mhm.
Is that related to gut stuff too, or?
I think that honestly, all of it is related because
Mm,
again, think about, so this is like, I have a book that I'm finished with that's going to come out soon, maybe. That's a whole story. But I wrote a whole book
I
about
know,
how
I'm
your
aware.
gut affects your hormones.
Yeah.
And literally, what I truly believe is that when your gut is dysfunctional, remember your vagus nerve connects your gut to every single system in your body. When your gut is dysfunctional, your vagus nerve is telling your entire body something is wrong.
Right.
Your insulin levels are higher, your cortisol levels are higher, your CRP levels are higher. I mean, all of these inflammatory markers are high, right? And so when your gut is leaky and you have the wrong things talking, then these signals are leaving your gut and going to all your organs and telling your organs that. It rises your insulin, it raises your cortisol, it affects our thyroid, it affects our hormone production, it affects our sleep. And so I really do think it affects our leptin. That, I mean, do all those things affect your blood pressure? Well, of course they do.
Right.
And then it's going to affect what food you crave, how much salt you eat, how much sugar you eat. And so it's pretty interesting. And I don't know if you know this. I didn't know this until I started looking at gut, but do you know that we have 100 times more DNA in our gut than we do in the rest of our entire body? 100 times more just in our GI tract. So that's been validated. So how is it that we think, as a traditional medicine doctor, that we could fix anyone in any way without focusing on their gut? When we have 100 times more data here and it's talking to every organ in our body all day long, how are you going to fix someone without at least acknowledging the fact that maybe we should look at it, right?
Yeah. I mean,
just a thought.
Well, we could talk about this for another 2 hours, but we have another podcast to record as well, me on yours. I want to ask you something totally unrelated to medicine. You don't look like your last name would be Smith. Is that your married name, or are you a Smith?
Nope, I'm a Smith. I get that a lot. I get asked, like, are you from Lebanon?
Yeah, I was going to say.
Eastern? So the funny thing is, I was actually born in Lebanon, Missouri. Oh. And there's a pretty big
from Lebanon, then. There you
go. I am. There's a pretty big Lebanese population in Oklahoma City, and I have a lot of friends that are Lebanese, and so they call me their Lebanese sister, which is not untrue because I was born in Lebanon, Missouri.
Of course.
I'm not I need to do a 23andMe. I'm not super sure what my background ethnicity is, but my dad's last name is Smith. He's a white guy with gray hair. I mean, he had darker hair when he was younger. I think he told me he thinks he's like English. My mom is German. She's like 6'2" and had red hair.
How tall are you?
I'm only like 5'7". My dad is short. So I look like my dad, and my sister looks like my mom. My sister is very
shorter than your mom?
A lot shorter. Yeah.
Oh, that's awesome.
Yeah. And you don't want to make German women angry either, especially when they're taller than you. Yeah. But
definitely.
I know. And so I don't know. But my hair is not quite this dark naturally. As we get older, I think we want to be darker because it makes us look younger, right? But I do have pretty dark hair in general. But I need to do a 23andMe because I get asked that all the time. Like, where are you from? And I'm like, here. I need to make up a good story.
Yeah. I'm sure a lot of women are going to want to reach out to you. And I know you're modern endocrine _ on Instagram, but how can they work with you? Like, how can women find you? How can they work with you?
Yeah, thanks for asking. We have a website, modern-endocrine.com. But yes, Instagram is a great place because I try to put good educational information like you on Instagram. And I do Instagram lives, or just like these live webinars once a month where I just talk about gut health, and it's free. And we put it on Instagram all the time, like comment live, we'll send it to you. It's a Zoom. But you can look on my Instagram page. We have information there. Our website, we have a whole become a patient. And if you're one of your patients, like we just do gut health too. So like, I don't want to steal your patients. You're a great gynecologist. You do hormones. And I don't take McCall's patients, like do your thyroid stuff with McCall. But if you just want to do gut stuff, we have that option. If you want to do everything, we have that option. I just really love meeting and connecting people like you, McCall. Like, it's just really cool when you're in a space where you really actually help people, right? Whatever that looks like for that person, kind of meeting people where they are. And that's what we try to do. Like, you want to do everything and do an overhaul, fine. I have people that I see that we just do peptides. I have people that, hey, I just want to focus on my gut. And we're happy to help and like support you in any way possible, because it's just really cool to think about, if we could make everyone in the world 10% better, how cool would the world be? Right? Like, it would just be.
Just so everybody knows, if I'm in a room with McCall and you, I would be the dumbest person in the room. So
I doubt it.
Last question. What's the best peptide, since you mentioned it, for gut?
Oh, for just straight for your gut,
Yeah.
KPV with BPC. So you can do an oral BPC KPV combination. There's one called Gut Tide out there, but KPV is really good for your gut, as is BPC, but they put one together and it is
Oh,
phenomenal.
great.
Yeah.
All right. Dr. Carrie Smith, Cassie, sorry.
That's
Just
okay.
replace the S's with R's. Dr. Cassie Smith, Modern Endocrine, modernendocrine.com _ on Instagram, modern-endocrine.com. Thank you so much for coming on. We've been planning this for months and schedules and whatnot, and I really appreciate you coming on and sharing all this. We could have talked for 2 hours.
Thank you for having me, and thank you for being so great to all your patients.
So, thank you. Thanks for listening. If you enjoyed this episode and you'd like to help support the podcast, please share it with others, post about it on social media, or leave a rating and review. To catch all the latest from me, you can follow me on Instagram at Shawn Tassone MD, or on Twitter at TassoneDoc, and on Facebook at America's Holistic Gynecologist. If you're really interested in your hormones and you want to do a deep dive, get my book, The Hormone Balance Bible, on Amazon or other major retailers. Thanks, and I'll see you next time.